Good afternoon, everyone. Welcome to Dementia on Demand, exploring advanced dementia healthcare gaps for patients and their caregivers. What makes an advanced dementia diagnosis unique? There's a couple of things. The majority of diagnostic screening involves neuropsychiatric testing, MRIs, blood work, physicals, and long wait times to see a provider. And as you can imagine, for those who have advanced dementia, a lot of times it's hard for them to be able to schedule because there's long waiting times. And it's also very difficult for people to subject themselves to such rigorous testing when they don't necessarily have the cognitive abilities to be able to follow directions or to calm themselves, because sometimes these tests can be anxiety producing. And also, at this point in a diagnosis, these types of diagnostic screenings aren't necessarily useful in terms of being able to provide further treatment for these patients. So the question then becomes, how do we ethically manage symptomatic patients with no dementia diagnosis? So we routinely diagnose dementia, but we don't routinely screen for those who may be at risk for advanced dementia symptoms. So what's important is to think about what kinds of patients in our patient portfolio that may be at risk for this kind of medical issue. So people who generally have vascular issues, alcoholism, early onset dementia, Lewy bodies, history of a traumatic brain injury, people who may have had a stroke and have some sort of underlying cerebral infarction, as well as people who have chronic untreated neck or back pain. These kinds of diagnoses for providers sometimes can provide us insight in terms of being able to say, okay, this is a patient I might want to be a little more upfront with in terms of what could be possible for this family in terms of they might be having a lot more agitation or anxiety. And that can make all the difference in terms of people being able to plan proactively to keep their loved one at home. What else is important to consider is that there are no specific blood tests or screening tools for these specific risk factors. So part of it is a little bit that, we're as, clinicians and as care providers and as professionals in this field, there is no real hard and fast rule in terms of diagnosing these particular symptoms or addressing them. So that's why it's important for us to collaborate and to continue the discussion about how we can help these families. One of the ways that we can look at these patients is through what's called a functional assessment staging tool, or FAST, that is specific for dementia. And if you look down the left-hand side, you can see the stages. And based on the FAST tool, there are 7 stages. And where I start to see patients really needing this advanced behavioral assistance is down here in the late 6s, early 7s. And this time and on this scale, these stage 6 and stage 7 also aligns with when people may become hospice appropriate, or it might be best if there was some sort of palliative or chronic care oversight for the family at this point. Because the person at this point is having a much lower level of awareness, a lot of times they aren't aware of the date and time, or they're not aware of maybe people in their family who they used to recognize, and other common factors that would be of regular or normal orientation. So what we try to do is to use the FAST scale as a way. It's a scale that's already in existence that clinicians can use to help gauge where somebody might be on the dementia continuum. And to complement the FAST scale, we have the palliative performance scale. And again, if you go down the left-hand side, you can see the percentages and how that they decrease in terms of the advancement of any disease process. unlike the FAST, the palliative performance scale is not specific to dementia. It can be used in any kinds of advanced chronic care management. But again, if you look down across the 50 or 40% line, this is really where advanced dementia symptoms begin to emerge or worsen. This is where we start to see ER visits, caregiver burnout, and those kinds of things. A lot of staff burnout on the units. You might be seeing violence in memory care or other places. Again, that 40% is usually a hallmark of patients who are either hospice eligible or they may be hospice eligible soon. So it's always important to keep that in the back of our minds in terms of a plan of care for these patients. You also might want to notice that next to the percentages, you don't have to have every box checked. So for instance, you could have somebody who is walking, but they're mainly assistants and they're confused. So you don't necessarily have to be mainly sitting or mainly lying in bed to qualify and to fall underneath the 50 or 40% category, which sometimes throws people off because people think, well, if they're walking, they must be, not that bad off. But these patients can decline quite quickly in the last few months of their life. One of the treatments and one of the interventions we can consider to help these patients is proactive psychoactive medication use. And with any kind of medication, of course, we always look at the safety and efficacy profile. But when it comes to psychoactive medications, we also need to add the ethical implications as well into our calculus. One of the, it's obviously, there's the old adage with the geriatric population where you start low and go slow in terms of medication administration. And that certainly holds true for the psychoactive medication use as well. However, there are times when it makes sense to be proactive and start patients on these kinds of medications, because rather than have sort of a crisis kind of lifestyle where there's a lot of ups and downs, we could actually sort of taper that down. And, we might have little episodes here and there, but if we start the medication and education with the family earlier on, the patient definitely would have a much calmer decline, if you will, and that ultimately the goal would be able to keep the patient at home. So proactive psychoactive medication use actually can be a way for people to try and keep their loved one at home. There's a lot of fear surrounding these medications, but with the proper supervision and with somebody who's qualified to prescribe the medications, it's amazing what can be accomplished. Currently, we have these cholinesterase inhibitors and other types of medication that are out there in terms of trying to maybe slow the disease down a little bit or increase your alertness. But unfortunately, they don't necessarily work that well. They may in the very beginning for people with mild cognitive impairment. But once we get into advanced dementia in that like stage 5, 6, or 7, these medications no longer really have the use. And sometimes it can actually contribute to other side effects. So it's worth talking with your patients and families about whether or not it makes sense to continue on these medications. So that's pretty much it for this topic. Moving along. So advanced dementia gaps in home and care, let's talk about at home. One of the biggest issues is caregivers don't know what help to ask for. We meet these caregivers who are burned out, they're frustrated, they're tired, they're grief-stricken, they're lonely, they're isolated, they're hopeless and helpless, but they have no idea what to ask for. And that really puts the onus back on us as professionals, that it's our job to educate families early and often about what could possibly happen with their loved one with dementia. I use the analogy of a mammogram in that that's something that's become very commonplace in terms of the general public is aware of the word mammogram. If somebody were to find a lump in their breast, they would think, they won't necessarily do it, obviously, but they definitely would understand that asking for a mammogram makes sense. Whereas there is no standard test, there's nothing out there that people can reach for. We also run into the factor of embarrassment by and for their loved ones. People don't want to be talking about their loved ones. Sometimes they feel like they're betraying them. So a lot of this might be kept behind closed doors rather than out, be discussed out in the open. The primary care provider is usually the provider that's closest to the situation. But the question becomes, are they comfortable as primary care providers diagnosing dementia? Now, there's no hard and fast rule that only neurologists can diagnose dementia, or psychiatrists, or any other neurological professional has to be the origin of the diagnosis. It is within the purview of primary care providers to be able to make that diagnosis. And that's something that as providers we can really do, because sometimes families go around where we all sort of talk about someone's memory loss and nobody necessarily maybe wants to take the initiative and put that diagnosis on. But if, once we do some, the mini-cog and some other testing, something you can easily do in an office visit, that's enough really to be able to qualify for somebody for the dementia diagnosis. Continuing with the gaps at home, there's a lot of use, as we were talking about, of the psychoactive medications. One of the medications that I find is extremely effective is clonazepam, which, as you know, is a benzodiazepine that is short acting in that, it wears off after a few hours, but the trajectory is a lot smoother and softer than, let's say, an Ativan, which has, 2 hours up and 2 hours down. So the Klonopin, if administered at low doses on a regular basis, can really help to decrease the underlying anxiety or agitation that could be building within a person afflicted with this horrible disease. So it's something, obviously nobody's looking to provide benzodiazepines to older patients. But in this instance, it may in fact just be the greater good, because that might be the difference between being able to stay home and age in place, or winding up in the hospital frequently in need of a geriatric psych evaluation and then placement in the dementia unit. Moving on to dementia gaps in senior living communities. Senior living communities are wonderful in that there's many areas of expertise within the units. There's lots of support, but at the same time, sometimes there's not that geriatric psych support specifically offered in, let's say, assisted living and memory care. So these patients are sort of, the staff is sort of forced to reconcile, like, how are they going to deal with somebody who's verbally or physically assaulting or battering people? How do they deal with people who are aggressive and wandering and being much more physical in terms of their demeanor? And it's almost sort of like the well-kept secret, if you will, not so well-kept secret, if you do work in these communities. There's always a patient or two or more who have these kinds of issues, and it completely destroys the dynamic on the unit. And staff are often forced to live in fear because they're afraid if they say something, they might lose their job. But what would really help the situation, ironically, might be something like a benzodiazepine like Klonopin to be able to bring this person's agitation down, which then might impact the whole unit in a more positive way. So advanced dementia care gaps in the healthcare system is the third topic. A lot of times what happens with these patients, if they're not identified early enough, they wind up going to the hospital repeatedly because something happens at home. Either the patient wanders, or there's an altercation, or there's some sort of unfortunate incident that maybe the police are called to get involved, or the EMTs are called, and it becomes much more of like an intervention that is definitely a crisis kind of situation. And that is extremely agitating to both the patient and the family. And again, we sort of talk about how, even though it's for the greater good for these people to go to the hospital and have a geriatric psych evaluation, if only we could have been more proactive and prevented it, or at least tried to, that might be able to help smooth this process, or in some places, maybe even eliminate it altogether. So when you think about if you are in the hospital, or if you've ever worked in a hospital when a patient with advanced dementia comes in, there's not enough staffing. These patients need one-to-one care. They need somebody to be with them, to reassure them, to redirect them. And in a busy unit such as an emergency department, there's really no opportunity for these patients to be adequately served. What happens then is that these patients sort of come in and out very quickly because no one really wants to admit them because there's not much to be done. And also admitting them would require disrupting a unit, if you were to admit them to med-surg or somewhere else in the hospital. So it's very difficult because, again, the caregivers are crying out for help. The patient is crying out for help, but no one really knows what to ask for. So a lot of times it requires an inpatient geriatric psych evaluation, which separates the family and the patient for, could be 2 or 3 weeks or a month at a time, where multiple medications are tried. And even that may not necessarily be successful, but it's definitely very traumatic for everyone involved. One of the analogies I like to draw with these kinds of patients in a hospital setting is to consider that they may be, in fact, intensive care unit patients, if you were to look at it through a lens, in that if they're qualified or could be qualified for hospice, or they're approaching the end of their life, if that were somebody in a cardiac situation or a respiratory situation or another kind of situation, we would be looking at them as an intensive care kind of patient, or at least maybe through more of a medical lens. And that's really the level of care these patients need. But obviously, the intensive care isn't necessarily the best place for these patients. So when you look at the numbers, the readmission rates for advanced dementia patients are astronomical. And that, again, could be a trigger for hospital providers to be able to say, or people who are caring for people with dementia in the private industry, wait a second, once you start seeing those hospitalizations, maybe we are really looking at an advanced dementia case. How can we break that hospitalization cycle and create a more healthy environment for the patient and family? So let's hear some solutions. So palliative and hospice care and dementia, and they all go hand in hand. This really is the key, is being able to assemble a team of people who understand what it's like to approach a patient from a comfort care perspective. These words, now that being said, these words, palliative and hospice, can create a lot of anxiety and tension in family members. A lot of times people are afraid, oh, you're telling me my loved one's going to die. I don't want them on hospice because I don't want to hasten their death. As we know, that's not the case, but that's certainly something that's a common misconception in the public. So it's important, again, if we bring up these conversations earlier in the process, by the time the families and patients need these services, it's not the first time they're hearing them. It's very hard for people to hear this information and process it in a crisis. So even though it might not be pleasant to have these advanced care conversations, or it might not necessarily be something we've had a lot of experience with, I can attest to the fact that the patients or the families that I speak to, frankly, about this are 99% of the time very grateful that somebody approached them about this. Because in their heart, they know that their life is coming to an end. Not tonight, not tomorrow necessarily, but the elephant in the room is life expectancy. And if we understand that some of these patients are palliative or hospice appropriate, we might be looking at months or maybe even a year or two, versus a family might be thinking, oh my gosh, I can't do this for another 10 years. When we know, in fact, there's no way medically this is going to go on for 10 years, but we know that, but the family doesn't know that. So the way is, how do we create an environment where that information can be well received, and how can we deliver it in the gentlest way possible? Another important part of partnering with hospice and palliative care is that they start to talk about end of life processes. People tend to think with dementia, oh, well, if I, what does death by dementia look like, right? Is it your brain all of a sudden stops working, one day, like that's how it all ends? But that's not really the case. What often happens is that people might have a urinary tract infection or aspiration pneumonia, and they wind up going septic and then quietly passing away. Now, getting to that point is anything but quiet. That's where the multiple hospitalizations and the chaos and the confusion and the fear come in. So the goal would be to help families and patients, if they can, understand what the end does look like, and that it actually can be more of a quieting down rather than some sort of violent, painful death, which many people do fear. Another important part of talking about patients with advanced dementia is, it goes along with the aspiration pneumonia, is that dysphagia is absolutely a symptom of the end of life. Not tonight, not tomorrow, but probably within the year. People by nature want to feed their loved ones. We want to care for our loved ones. We gather around a table to celebrate and support one another. And the fact that they've been robbed of so much of their loved one, the fact that now they're being robbed of the very ability to feed their loved ones, is particularly painful. One of the hospice criteria for Medicare is that for dementia patients is that they may have they lost 10 pounds or more in the last year. And you'll see in your patients that if somebody has lost 10 or more pounds in the last year, it's definitely a red flag for somebody with advancing dementia. Just like their brain is quieting down in terms of their memory, their ability to swallow starts to quiet down, their ability to digest starts to quiet down, and that we start to venture into that territory of feeding tubes. And how are we thinking about artificially hydrating or providing nutrition? So again, this is another opportunity to be proactive with these kinds of ethical and moral discussions with our patients. So what if we thought about having 911 dementia-friendly services? What if we started dementia urgent cares, or we actually had regional hospitals that were specific for people with cognitive needs? They would obviously be staffed differently, and there would need to be a much different way of operating in terms of there'd be caregiver involvement. You couldn't necessarily have a waiting room and then the patients come into the back, which is more the traditional medical model. It would definitely need to be more of a holistic way of integrating the care into both the patient and the family. And that there would need to be a tremendous amount of social support on staff to be able to counsel families and to provide this desperately needed education, as well as not just the education, but also the options. And that what are your options given the facts? And in my experience, once families understand the medical facts, it's much easier to discuss the other decisions that need to be made. But if you can help a family understand where their loved one is, look, they're on stage 6. Do you see the FAST scale? There's 7 stages. It's horrible information to hear. Nobody wants to hear it, but it gives people a sense of timing, and it helps ground them in the reality of their loved one's condition. So the more that we can give people that kind of information so that in their mind they have a bit of a time frame, it makes all the difference in the world of allowing families to be able to emotionally and practically prepare for their loved one's declining condition. And with that, I will open it up for questions.